In Harvard Medical School in Boston, Massachusetts, and we are live at HFSA 2022 in Washington, D.C., just after the dedicated session on intravenous iron in heart failure. I'd like to summarize the key take-home messages. Testing for iron deficiency is of critical importance because this is a comorbidity that is highly prevalent in the population and is associated with excess risk of near-term hospitalization and death. The testing for iron deficiency can be achieved with relatively simple iron indices such as transfer saturation and ferritin, and these can be even added on to existing laboratory draws that have already been used in clinical care. The treatment of iron deficiency has been a topic of multiple randomized clinical trials. Intravenous ferric carboxymaltose has been studied in multiple relatively modest-sized trials, including FAIR-HF and CONFIRM-HF, that have demonstrated important improvements in clinical outcomes such as functional status and health-related quality of life. In addition, a trial called AFFIRM-AHF was a trial of acute decompensated heart failure of over 1,000 participants and showed a substantial reduction in hospitalization risk over a 1-year time horizon after hospital discharge. This is an exciting time in iron preparations, in which we have 2 to 3 large-scale trials that will report to evaluate the use of intravenous iron in patients, including chronic heart failure with reduced ejection fraction, namely the HeartFit study, the largest randomized clinical trial to date on this topic, the Ironman study, and the FAIR-HF2 study. So multiple randomized clinical trials in the pipeline. Now that guidelines have actually been updated in both the United States and Europe to recommend the use of intravenous iron, not only for functional status and quality of life improvement, but in Europe, in addition, to improve hospitalization risk amongst acute heart failure patients. The time is now for implementation, and so we need to create dedicated streams of implementation pathways to improve the translation of the clinical trial evidence to our patients. And importantly, while oral iron is common, inexpensive in clinical practice, unfortunately, when tested in clinical trials, it is ineffective at improving clinical outcomes and is slow to actually replete patients with replete their iron stores. So intravenous iron poses a relatively short-term strategy that can effectively replete stores and also influence health-related quality of life, functional status, and even clinical outcomes.